Thank you, Audrey. And I will turn it over to Vicki Lowe, our chair
Sorry.
uh, of the Universal Healthcare Commission.
I'm
Thank you, Vicki.
sorry, not used to the fancy equipment. Good afternoon. I squatchy Vikilo since Nastatitlam Nuskliam, since not Nutzlak. Welcome to the Universal Health Care Commission meeting for September. It is 2:01 and I call the meeting to order. I would like to begin by giving a land acknowledgement. I would like to begin by acknowledging that as we gather today, we are on the ancestral homes of Indigenous people throughout the state. Indigenous people, despite being removed from lands where they lived, hunted, gathered, practiced ceremonies, and cared for their community members, still care for these lands. Indigenous people and tribes, whether officially recognized by the United States government or not, continue to care for these lands and their community members. As health professionals, it is important that we also acknowledge the impacts of the removal from traditional lands, of children stolen to boarding schools, and of the oppression of culture and traditional ways of life on the health of Indigenous people throughout the country and in Washington state. As we work to improve health in Washington state, it is imperative that we address the inequities of the past by understanding their impacts of the present. I invite each of you to learn about and understand the true history of the Indigenous lands where you live. Thank you. Well, and now I'd like to give a warm welcome to all our commissioners. Thank you for joining us today. We do have a few new members, and I'd like to give them an opportunity to briefly introduce themselves. I know Senator Cleveland, you were kind of almost officially with us last time, so if you want to go first.
Thank you, Madam Chair, and hello, everyone. I'm very pleased to be joining you today. I'm Senator Annette Cleveland. I represent the 49th Legislative District, which is located in Southwest Washington, encompasses most of central Vancouver and parts of Clark County. I also have the privilege of serving as the current Senate Health and Long-Term Care Committee Chair, and I'm really excited to be joining the commission as a member, formal member. I've watched your work closely and just look forward to working with each one of you as you continue to make progress and move forward. So thank you, Madam Chair.
Thank you. And Representative Parsley was going to be with us, but I think she is in an area where she doesn't have reception. So if she does join us, we'll give her a moment. And then also in the room with us today, we have Dr. Tao Quanget from the Department of Health. Dr. Quanget?
Thank you, Chair Lowe, and hello, members of the Commission. I'm Tao Kwan Get. I serve as State Health Officer at the Department of Health, and I am a pediatrician by training and also have worked at the local level as an epidemiologist. And it's just such an honor to join this group. I share the vision of universal health care and am looking forward to learning how I can contribute to your work. Thank you.
Thank you. I also want to let commission members know that Stella has resigned from her position. The governor's office has been informed as they are in charge of appointing our vacant governor appointee seats. So they'll be working on that. So now we can do roll call. Oops. Am I doing roll call?
Yeah.
Okay, sorry. And now we'll do roll call. So just let us know that you're here. Joan Altman.
I'm here. Hey, Vicki and team.
Hi, Joan. Jane Beyer. All right. We'll come back and check on that. Senator Cleveland.
Here.
Nicole Gomez.
Hello, everyone.
Hi, Nicole. Dave Ensminger is not here, and he has sent Teresa Tamara as his representative. Teresa?
Hello, Teresa Tamara, Operations and Engagement Strategist with the Strategy, Policy, and Innovation team here at HCA. Happy to be here.
Thank you. Dr. Quanget.
Here.
Vidisha Mandal,
Here.
and Representative Parsley, just checking to see if they were able to join. Nope, okay. Omar Santana Gomez. Representative Schmick.
Here, thank you.
Hello. And Mohammed Shadain.
Here, thank you, Vicky.
Thank you. All right, we have a quorum. Now we will vote on approval for the June minutes. Is there any discussion on the minutes or any proposed changes? June was a little while ago, but is there a motion to approve the minutes?
Motion to approve?
Thank you, Nicole. Can I
I
get
second.
Oh, thank you. Is that Mohammed?
Yeah, yeah.
Thank you. All those in favor say aye.
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 Any opposed say nay. All right. And Jane has joined us. Hello, Jane.
Hello. Thank you.
Thanks for being here. All right, if you go to the second tab in the book, we have public comment. Since our last meeting, we've received 6 written public comments. These comments include support for public health care, guidance on governance, recommendations for transitional solutions, background on provider reimbursement, and a request that the commission develop visions, values, and principles and recommendations for next steps after the Advocates Roundtable. Commission members received these written public comments as part of their full meeting packet last Friday for review. Individuals may also provide public comment during our meeting, and we will hear from them now. For those online, please use your Zoom feature to raise your hand. You will be moved into the panel when you are called upon, and this may take a moment before we can hear you. There's like a little gap, but also if you're talking, we'll hear you right away. When you are called upon, please state your name and any affiliation, who you're speaking for, and we will be displaying a timer. As a reminder, there's a 90-second limit. When the timer stops, please stop your public comment. Ross, would you please start with the names of individuals who signed up to provide public comment?
Yes, thank you, Vicky. Our first public commenter is Jean Hildy. Again, we have a 1:30 limit today that will be shared on your screen. Did I get the wrong? Oh, perfect. My apologies. I was reading off an outdated list. Our first public commenter today is Catherine Lewandowski. Please go ahead and unmute yourself, Catherine, and go ahead.
Oh, hello. Thank you very much for letting me give public comment. My name is Catherine Lewandowski. I'm the board vice chair of Pole Washington, and I'm a retired registered nurse, although I did just pick up a part-time job because I'm feeling a little insecure economically on what may happen. Anyway, I wanted to thank you for the wonderful meeting that you guys provided for all of the organizations, the roundtable. It was awesome. And I also wanted to say, I've heard some of these concerns about the other organizations worried about where governance is being placed. And I was looking through that information before this, and I noticed it's like enrollment and then infrastructure and then governance. And I think I have to agree with the other organizations. And wouldn't it make more sense to look at the governance and then let the governance whatever's created by you, look at enrollment and infrastructure? I don't think you don't have to do it all. Well, it's a big job we're talking about. I think we need to start expanding and including people that can actually get this work done. So thank you very much for all your work. We're here at the fair. I don't know if you can see my background because I can't tell I don't know how to take my background off, but we're here at the fair and we're having a great time. We've got our booth all set up. And if you have a chance, stop by and see us. We're here for the next 3 days. Okay, have a great day. Bye.
Thank you so much, Catherine. And thank you for your advocacy and being out, sharing information. I appreciate your comment today. Next up, we have Emma Heinonen, and I apologize in advance for that pronunciation, but please go ahead, Emma. You should be able to unmute yourself.
No worries. Can everyone hear me?
Yes.
Perfect. Greeting, good afternoon, commissioners. My name is Emma, and I'm a member of Washington CAN. I work as a medical administrative assistant, and my role includes insurance verifications and obtaining prior authorizations. Today, I'm raising my voice for transitional solutions to reduce administrative complexity and healthcare prices. Since billing practices and health plans are so complicated, a lot of our patients are confused by charges and don't understand why their bill isn't fully covered, even when their providers are in network. Further, patients are routinely shocked when they receive billed charge estimates of $600 for a 1-hour evaluation and $300 for a follow-up appointment. There's been many attempts at insurance reform, but they're falling short and costs are continuing to rise. So I think that we need to reduce prices. Greater administrative efficiency of reduced payers and transitioning to negotiated global budgets for hospitals and providers are all ideas that could meet this goal. Even as someone who studies insurance benefits every day, I still spent 3 hours crunching numbers and comparing coverage plans when I selected my health plan for 2025. For universal healthcare to work, we need transitional solutions that simplify administration and cap prices for patients and taxpayers. Thank you.
Thank you so much, Emma. Appreciate that. Next, we have Lynette Sargent. Please go ahead, Lynette, and unmute yourself.
Good afternoon. My name is Lynette. I'm a parent, a volunteer in my community, and a member of Washington CAN. I'm a Washingtonian with complex healthcare needs, and am deeply concerned about the healthcare crisis growing in our state and in our country. Costs are out of control while true access to quality care has rapidly declined. We can afford universal healthcare. We cannot afford what we have now. With federal budget cuts and rapid provider consolidation, I am worried about service reductions like the closure of the clinic in my town. Where will patients go if there's no Medicare provider or public hospital left in Southeast King County? Having a plan that no provider in your area will accept equals no access. We need to do better for the people of Washington State. Healthcare must be seen as a part of infrastructure or a public utility rather than a privilege. This is a challenge that needs to be addressed in stages. We must ensure any short-term measures our state takes to cover people who will use care on the exchange or Apple Care can be scaled up to address the systemic problems of fragmented access to care and administrative policies that prioritize profit over patients. Washingtonians need healthcare to be able to participate in our communities, in our economy, and in the life of our great state. We need to know that we can provide for the well-being of our families. I am here today to ask you as commissioners to craft transitional solutions that allow us to meet coming losses in access, as well as to build a universal healthcare system to help our state thrive. Thank you for your time.
Thank you for that comment, Lynette, and for joining us today. Greatly appreciated. Next up, we have Marcia Stedman. Please go ahead, Marcia, and unmute yourself.
Okay. Hi, everybody. Chair Lowe, commission members. My name is Marcia Stedman, and I'm a board member of Healthcare for All Washington. I'm highlighting 4 recommendations for your discussion on transitional solutions outlined in our August 13th letter. Consolidate and expand state purchasing of healthcare PEB and SEB plans, allowing the healthcare authority greater leverage in healthcare purchasing and helping the commission meet its charge to develop a unified finance system. Also expand efforts to enroll local government entities in PEB to further enhance healthcare authorities' purchasing power and potentially reduce healthcare costs for local jurisdictions as existing law does permit. Endorse legislation that limits the health benefit exchange to offer only standard plans that have the same benefit and cost sharing structure across carriers, helping customers make apples to apples comparisons between plans, providing clear choices based on premium, network, and quality. 80% of current exchange members are in a standard plan. continue to simplify administrative requirements and prior authorizations. And 4, adopt strategies to ensure that healthcare decisions made by patients and their doctors are not overridden by persons not licensed to practice medicine. And finally, regarding the straw policy proposals, since Medicare beneficiaries are excluded from state-financed systems, we recommend that the Commission explore having the new system offer supplemental secondary coverage for those health services not covered by Medicare. Washington is already doing this for some 86,000 low-income Medicare beneficiaries through its Medicaid, elderly, and disabled coverage. Thank you for this opportunity to present these recommendations.
Thank you so much, Marcia, for those comments. Next, we have Annie Fitzgerald. Annie, would you please unmute yourself and go ahead? We'll just give Annie a moment.
Give me 1 second.
Sure, no problem.
Can you hear me okay?
Yes, we can hear you.
Okay. Chair, commissioners, thank you for the opportunity to speak. My name is Annie Fitzgerald, and I come here as a disability justice organizer with Whole Washington. I urge you, do not consider using the Medicare Wiser model, which many are calling AI death panels, as any sort of example for the Washington Health Trust. Wiser is a CMS demonstration of algorithmic prior authorization in traditional Medicare using AI-enabled vendors rewarded for denials rather than care, a profit incentive misaligned with patient needs. The model threatens timely access, especially for disabled people, elders, rural communities, and those of us already burdened by systemic inequity. The American Medical Association cautioned that Wiser would expand prior authorization deep into traditional Medicare, increasing delays, costs, and provider burden. AI-driven prior authorization is inherently opaque. Algorithms can't feel lived experiences. They can't account for nuanced disability or chronic illness. They formalize bias, invisibilize suffering, and monetize barriers. The Wiser model would enact opaque gates between patient and provider, replacing humane judgment with rigid algorithmic thresholds. Reject Wiser and reject AI-based prior authorization models. Use instead care models that are publicly governed, transparent, and built around human needs, not denial quotas. Let us build a Washington Health Trust that upholds healthcare as a human right, not a technological obstacle. Thank you.
Thank you, Annie. Appreciate your comments today. And finally, for our signed up speakers, we have Kate Rhodes. Kate, please unmute yourself and go ahead.
Good afternoon. My name is Kate, and I live in Pierce County and work in healthcare. I'm also a member of Washington Community Action Network. I'm deeply concerned about the healthcare crisis in our state, given federal budget cuts and new requirements for Medicaid. In this environment, the Commission's work could not be more urgent. Hospitals and individual providers have been struggling for years. Low reimbursement rates, delayed reimbursement, and high administrative costs have made our fragmented healthcare system increasingly untenable. If no providers in your area accept your plan, or it takes months to get appointments, or you're too afraid of high prices to use insurance, what good is that coverage? The prices in healthcare are way too high. We need to remove the profit motive from healthcare and treat it as a public good. We must remove the middlemen who are barriers between patients and care, costing us billions. A simplified system with a single payer will be lower cost to administer and provide fewer avenues for fraud. In short, please consider how transitional solutions for universal healthcare can be implemented with an eye toward the immediate solutions needed at the state level for all the Washingtonians losing coverage in the coming months. The time for systemic reform is now. Thank you for your time.
Thank you so much, Kate, for your comments. Moving now, we don't have too many folks in the room, but don't want to prevent you from speaking if you'd like. Any public comments? Okay, we'll move to any hands that are raised. I saw that a Thomas Kennedy had a hand raised. I think it went down, but just wanting to see if, oh, great, okay. Thomas, you should be being promoted to a panelist now and being able to unmute yourself. And then you have 1 minute and 30 seconds, and please go ahead when you're ready.
Hi, my name is Thomas Kennedy, and I'm a volunteer with Whole Washington. I thought the community roundtable was very valuable, and we had great conversations. I really look forward to having more of these in the future and hope these can get on the schedule for 2026. The next piece I want to talk about is can the committee help us to make the Washington Health Trust as ready to pass as possible? There were some criticisms or commentary on the trust and its passability that were put out recently, and we would love your input moving forward to make it as good as possible. Also, January 1st, 2026, and even earlier, October 15th of this year, there are going to be some pretty big changes to what's offered under Apple Health with some MCO changes. This likely consolidation opens up the opportunity for the state to buy one of these MCOs or the community health plans and transition to a public insurance model for Apple Health. That would be a great way to transition towards universal healthcare. Thank you so much for your work, and I'm done.
Thank you, Thomas. Appreciate those comments. Is there anyone else that would like to provide public comment today in the audience? If so, please just raise your hand and we can get you converted over to a panelist and provide those comments. Okay, not seeing any others. This will close the public comment period. Just want to thank folks for taking the time for submitting comments in writing and attending today's meeting and providing comments. We greatly appreciate it, and I will hand it back to Vicki.
Thank you, Ross. Thank you, everyone, for your comments. As a reminder, the Commission welcomes and encourages public comments and appreciates all the feedback we have received. We heard some great comments just now. Public comment is an essential part of this process as it provides an opportunity for the public to have their voice and be heard in regular meetings. Public comment can be provided orally during our meetings or can be sent in written form at any time to the Universal Health Commission's inbox at HCA Universal HCC. Wow, that's a lot of H's at hca.wa.gov. And Audrey, are we going to put that in the chat so people can? Oh, it's in the next slide. Thank you. Because I'm sure nobody followed what I said. Oral public comments are not accepted outside the public comment period. And Commission members review and consider all public comments received, but generally will not respond in public. I know this makes it awkward for conversations, and we talked about that during the roundtable. If Commission deems appropriate, a response will be provided in writing or at the next public meeting. In addition to public comment, we also recently hosted our first Advocates Roundtable this August to hear directly from a panel of advocacy organizations. And please turn to tab 3 for a report out from that meeting. So I'm going to talk about what we heard at the meeting, and commissioners should feel free to add anything that might have gotten missed or anything that you really wanted to call attention to. First, I want to really thank all of our panelists from Healthcare for All Washington, Northwest Health Law Advocates, Washington Community Action Network, and Whole Washington for joining us. We appreciated the opportunity to hear directly from these groups and thank Ronnie Schur, Marcia Stedman, Emily Bryce, John Godfrey, Nathan Rodkey, and Andre Stackhouse, and Annie Fitzgerald for representing their organizations and providing such thoughtful response and feedback to our questions. I also want to thank our Commission and FTAC members for attending the roundtable. We had a great turnout with over a dozen members of the public that attended the meeting in person and roughly 75 people joining online in Zoom. Wow. The meeting recording is also available on the Healthcare Authority's website for the commission. During the meeting, commission and FTAC members reflected on the importance of addressing how our work is paced given our limited staffing and resources. There was also interest in engaging with the labor unions and labor organizations, and we were thrilled to learn that the Washington State Labor Council recently passed a resolution on single-payer healthcare. We weren't able to get to every question, but the advocates kindly provided written responses to each. These were shared with Commission and FTAC members after the meeting and also posted publicly in the meeting packet. We will also be including these written responses in the appendix of the annual report. I really appreciate the panelists' willingness to work with us to gather community input and help spread the word about our ongoing work moving forward. And they also, we talked about partnership and how we can work together to help get the word out about universal healthcare and garner more support. So I want to take this opportunity to open the floor up to any other commissioners that wanted to reflect on the Advocates Roundtable.
Vicki, this is Joan. I just wanted to echo your thanks for everyone for coming. I think it was a really helpful to put faces to the names that we see so often in the virtual ether. So really appreciate people taking the time to come to Olympia, and really appreciated getting to see and chat with folks face to face, and sort of HCA for hosting. In particular, things that stuck out to me, I really appreciated the written feedback and the nexus that folks shared in terms of how they are working with each other kind of across your various work streams. So that I found that incredibly helpful. It can be hard to know where to plug in or who to go for what emphasis. So I thought that was really helpful. I also really benefited from the thinking that a lot of these advocacy groups are doing around the nexus between the cost containment efforts and sort of particularly given our current budget climate. So I appreciated the sort of overlapping thought that people are doing, that connecting the work of the groups. That's definitely something that we try to do at the state agency level as well, but appreciated the thinking and the sharing around those two pieces. So thanks.
Thank you, Joan. Anyone else? And Joan, you reminded me of the, I know Representative Schmick asked for some of the data from NOLA, and the data that we received was very interesting. It showed businesses that have high participation in the Medicaid program of their staff. And so something really interesting to me, I think. All right, last call for comments on the Health Advocates Roundtable. All right, really want to thank everybody who was able to join for that special meeting. And now we're going to move on to tab 4 in our workbook. And as Audrey's getting there, today we're going to start with a brief update from the Healthcare Authority. Elena Sawyer, did I say it right? Senior Health Policy Analyst at Healthcare Authority will provide an update on the Rural Health Transformation Program work that's currently underway. Elena?
Yeah, can you hear me all right?
Yes.
Awesome, thank you. So hi, everyone. For those that don't know, my name is Elena Sawyer, Senior Health Policy Analyst with the Strategy, Policy, and Innovation Division at HCA, part of the team of people that has kind of jumped into action working on rural health transformation program work. As a lot of you likely already know, the Rural Health Transformation Program was established in H.R. 1, the One Big Beautiful Bill Act that passed in July, and it creates a $50 billion pool of money that will go towards rural health transformation spread over the next 5 years. What's written into the bill language is that half of that money will be distributed equally among approved states, and half of it will be distributed by CMS based on criteria, probably in consideration of population living in rural areas, proportion of rural healthcare facilities in the state, the situation of rural hospitals in the state, as well as other factors. I'm being a bit vague, partially because the NOFO, or Notice of Funding Opportunity, has not yet been posted by CMS. We're sort of waiting with bated breath for more details on that, and then we'll be able to provide a lot more information for everyone else. I think Ali is going to put in the chat some of the information that we do have. There's both a link to the CMS website as well as HCA has put on our website a slide deck with some of the details in the program that we do know, some information that we know about the timeline. We expect that the application will be due in early November and awards will be announced by the end of the year per language in the bill. But again, just waiting on that NOFO and hoping to get more information. Some things I can highlight, HCA, DOH, and DSHS are all working super closely as a team on this, along with the governor's office, and we're all having conversations with various stakeholder groups. We put out a public call for input that's on the website that Ali's linking to, and we've received over 140 responses so far from folks who wanted to provide input that can help support our application. There was also a listening session with tribes earlier this week. We have started developing some early priorities, again, waiting on the NOFO to totally solidify it. So these are subject to change, but based on the stakeholder conversations, the input we're receiving, and knowledge of what the federal administration is looking for in these applications, some of those early priorities include things like workforce programs, technology like expanded telehealth and AI for administrative purposes, chronic disease prevention and care management programs, and access to care, especially critical service lines like maternity care and behavioral health. I think those are all the details that I have for now. Waiting on that NOFO, hopefully any day now. And just we're doing everything that we can to maximize rural health transformation funds received by Washington.
Thank you, Elena. Any questions? All right. I know we're all kind of waiting for that NOFO. And now I want to welcome members to share updates that they have from either their agency or the work they do that align with the commission's work. And so we'll start with our agency representatives. Joan, you're first on my list.
Thanks, Vicki. Joan Altman, I direct our coverage strategies and expansion at the Exchange. Happy to give a few updates that I think might be of most relevance to this commission, and happy to take questions either during or after, to the extent folks are interested to hear and learn more. Top of mind for us, I'll defer to Jane to share more, but all of the plan rates for plan year 2026 on the individual market are being finalized. So to some of the comments that were made during public comment, notable premium increases coming for plan year 2026, layered on top of potential reduction or, likely / potential / like the NOFO still waiting to see if the enhanced premium tax credits are going to come or go for plan year 26, on top of federally driven changes in HR 1 and federal rulemaking that will all sort of work together to challenge access and affordability in the Exchange. So top of mind, we're sort of working on mitigation strategies moving forward to try to help lessen the impact in Washington. So part of that just looks like policy levers, and part of that looks like maximizing our Cascade Care Savings or our state subsidy program. Part of that also looks like working toward maintaining a coverage pathway for people without a federally recognized immigration status. So working ahead on all of those topics, to the extent any are of further interest, happy to come back and share more.
Thank you, Joan. Any questions, comments? All right, Jane, you are next.
Thanks, Vicki. So as Joan indicated, actually this morning or yesterday, the Office of the Insurance Commissioner announced the final rate increases for individual health plans. And as a weighted average, they came in at about 21%. And we do need to note that we have a whole team of actuaries that scrubs those rate requests. And if those rate requests are actuarially justified, in other words, if an insurance company can say, this is the premium revenue that I need to have coming in to pay for my claims that are going out, then we are required by state law to approve those rates. I think most notably, when we look at what was behind the rate increases, what we saw in the carriers' filings were in part, but not in major part, the impact of ending the enhanced premium tax credits that Joan referenced, with concerns by the insurers that as younger and healthier people who could no longer afford coverage dropped out of the individual market, the remaining folks who were in the individual market would be older and sicker. We also saw very, very clearly underlying cost trends. So both increased use of services, of healthcare services, and increased prices paid for healthcare services. And not surprisingly, prescription drugs figured in there significantly, as well as concerns about healthcare consolidation and impact on price. So that was what drove it. And we have been working with the Health Benefit Exchange over the past 6 months to try to figure out how to soften the blow for consumers when open enrollment comes around beginning November 1st. And we did adopt an emergency rule related to how the health plans structure their premiums to try to soften the impact of the loss of enhanced premium tax credits. And that rule is in effect for this upcoming plan year. And so what consumers will see is that the rates for the silver health plans have gone up significantly more than the rates for the bronze and the gold health plans. And the benefit of that, in an odd way, is that it drives greater premium tax credits coming to consumers to soften the blow of the increase in rates and also the end of the enhanced premium tax credits. So that's where we are on upcoming open enrollment. And as Joan indicated, the HBE is doing a great job of getting the notice out. None of this is uncomplicated for consumers who have to decide what plan they want to choose. And I know they're doing great work trying to give consumers a heads up, so it's not a complete shock when they see things, especially the folks with income over 400% of poverty, who are going to potentially lose all access to subsidies, increasing their premiums by up to $300 a month. So well over $1,000, $3,000 a year. It's a major hit for those folks. We are hearing that there is more and more consideration being given by Congress to include a 1-year extension of the enhanced PTCs in the continuing resolution that's currently being worked on. So we'll wait and hear more from Congress on that. And then on the other side of the lever, there's been a lot of concern and a lot of discussion about changes in required vaccine coverage at the federal level. And I do want to let you know that for individual health plans and for small employer health plans, OIC notified the insurers earlier this year that the vaccines and immunizations that they are obligated to cover this year and next year are those that were in effect in May of this year. So before the significant changes that we're seeing in vaccine coverage. And some of you are probably aware of the standing order that was issued by the Department of Health regarding pharmacists' ability to continue to do COVID vaccines without a consumer having to have a prescription. And for the legislators in our midst, we are working with the Department of Health to develop legislation for the upcoming legislative session to be sure that we're able to sustain coverage of preventive services in Washington state. So I think those are the two issues that were of interest. Happy to take any questions.
Thank you so much, Jane. Do you have handy, or could you put in the chat the citation for the emergency rule you referenced?
Yeah.
Thank you so much.
I can find that. Yep.
Any other questions for Jane? All right, Jane, you make a great segue into Dr. Kwon-Get from Department of Health.
Great, thank you. I'd just like to take a couple moments to give an update on two things. I can give a few more details on the statewide standing order that Member Byer talked about, and also the announcement of the West Coast Health Alliance with California and Oregon that was later joined by Hawaii last week. And both were stimulated by some of the confusion that has been caused by recent federal changes that Member Byer talked about. And for COVID-19 vaccine, we were hearing from ordinary Washingtonians just a lot of confusion when they would go to the pharmacy to get a vaccine. There was confusion about whether they were eligible, about whether the pharmacist could give it, whether a prescription was required. And so the West Coast Health Alliance was an effort by the governors of these states to really elevate and affirm the principle that that public health policy, including vaccine policy, needs to be based on the best available science. And as a start of that, the West Coast Health Alliance announced their support of guidance from the American Academy of Pediatrics and the American College of Obstetrics and Gynecology, two trusted national medical associations that have a strong history of developing evidence-based guidance for vaccines, and who recently came out with updated COVID-19 vaccine guidance. And then the American Academy of Family Physicians also came out with updated guidance for COVID-19 vaccine. So the alliance is in its early formative stages. The next goals for the alliance will be to firm up and provide more details on guidance for COVID-19 vaccine, and then look at vaccines for influenza and RSV to see how the states in the alliance can align their recommendations. I think there's a lot of concern by some that with the weakening of the federal capacity to make vaccine guidance, that there might be a fragmentation of guidance. With each state having its own or each region having its own guidance. And so our hope is that by referencing these national associations, we can avoid some of that fragmentation. And then Member Byer mentioned that the statewide standing order, that was an attempt to address the issue of patients being asked for a prescription when they went to get their vaccine. As we know, that's not a step that used to be required, but because of all of the confusion that has been generated, many patients were being asked for a prescription. Doctors' offices were wondering how they were going to provide prescriptions for so many people. And so that's why why we pursued a statewide standing order with input from the Washington Vaccine Advisory Committee. The Department of Health teams really had a great team effort to quickly implement the statewide standing order, which is like a prescription that a person can take to the pharmacy to get access to COVID-19 vaccine, and that way they don't have to approach their healthcare provider for vaccine for a prescription. And the statewide standing order also provides clarity that in Washington State, everyone 6 months and older who wants the extra protection of COVID-19 vaccine should be able to have access to it. And we really appreciate all of the efforts that OIC has done to increase coverage of COVID-19 vaccine, because without that, the standing order wouldn't have nearly the effect. And the standing order, I think there still are some barriers despite the standing order. There's questions about supply. There's still ongoing questions about federal guidance, but at least a standing order addresses one area that was impeding universal access to vaccine. So I'm happy to answer any questions about either the standing order or the alliance. Thanks.
All right. Any questions for Dr. Quanget? No, thank you. Good example of admin simplification, though, taking the prescription writing away from the doctor's office so they don't have to fumble with it. And Teresa is here on behalf of Dave Ensminger. Did he give you an update to give, Teresa?
I do not have an update, and if I did, it would likely have been what Elena Sawyer shared with us earlier about the rural opportunities. Thank you.
Yes, thank you. And any of our other members, our legislative commissioners, the Senator Cleveland or Representative Schmick? Senator Cleveland?
Thank you, Madam Chair. I'll just share very briefly an update on continued interim work focused on by our healthcare policymakers. I'm in the midst of planning two joint healthcare and behavioral health oversight committee meetings for this fall. So do watch for those dates and those agendas to come out very soon. I'm also beginning planning for the Senate Health and Long-Term Care Committee Legislative Assembly Days meeting that will take place in December. Those Legislative Assembly Days, I should have had a calendar in front of me, but I believe they are scheduled for December 5th and 6th, but I will double check my calendar here and confirm that for you. Finally, want to mention, just bring to your attention that interim work is also taking place for the Senate Health and Long-Term Care Committee to carry through on interim tour. And this year, the focus is on the long-term care continuum of care. So a lot of work will be taking place here in the months ahead leading up to January's 2026 legislative session. And I'll just state the obvious, with the many changes, particularly that are being driven by the federal government. It's critical for us as policymakers to follow really closely and create and ensure that there are these opportunities with these planned committee interim meetings to ensure that we're doing all we can to keep the public informed as well.
Thank you, Senator Cleveland. Any questions, comments? All right. Representative Schmick, do you have anything you want to share?
No, I'm good.
All right. Thank you. Any other commissioners have any ongoing work they want to share that's related to our work here? I'd say for the tribes that we're also working through understanding the impacts of the OB3 or HR1, whatever you're calling it. We have a lot of names for it. But I think the big thing, just kind of timing wise, is really going to be education about the impacts on American Indian Alaska Natives and the Indian healthcare delivery system. We're able to work with Secretary Worsham to get some language about tribal sovereignty and into the West Coast Health Alliance. So we're really pleased to see that happen and hope to see, sovereign to sovereign, the tribes working with the states to help keep people safe. Vaccines are very important in our healthcare delivery system. And we did have the rural healthcare listening session and talking about the impacts of rural health hospitals, especially almost all of the tribes are located in very rural areas. And because there are no Indian Health Services hospitals in the Portland area of IHS, we really rely on those rural hospitals. So really trying to think of ways that we can partner with hospitals. I'm talking about, is there a possibility for tribes to maybe lease part of a hospital and leverage more federal funds using a 100% federal match for the services there. So really just trying to think outside the box too, I think, as well as everybody else. All right, one last call for any other comments or updates. Okay. Now we're going to turn to tab number 5 in our workbook, and Allie is going to give us an update on our work plan. Allie?
Thank you, Chair Lowe. Hello, everyone. My name is Allie Power, and I'm a health policy analyst at HCA. I'm filling in for Mary, and I'm going to be providing a quick work plan update. Go to the next slide. This is just an overview of what we're going to talk about. Next slide. So to kick us off, here's the Commission's milestone tracker and where we are in the overall process. For today's meeting, we will be reviewing draft straw proposals for eligibility and benefits and services. This is a new format that we're piloting in response to Commission members' requests to further document our decisions. In a second, I'll be going over the next steps for the draft annual report. And toward the end of today's meeting, Chair Lowe will lead us in a discussion of next steps for transitional solutions. Next slide. So the draft 2025 annual report was sent to Commission members on Thursday, August 28th, and it's also included in the appendix of today's meeting packet. The final report is due to the Ledge on November 1st, and following today's meeting, HCA staff will update the draft to include any action taken today. Staff will then circulate the updated draft, and the Commission will vote to adopt this final report at their next meeting on Thursday, October 9th. Commission members are encouraged to review the draft and send any edits, comments, questions to the general mailbox noted here on the screen or directly to staff. We also have time now if Commission members have any feedback they'd like to share. So I'm just going to pause. And if you've had a chance to review the report and you have any feedback you want to give live, I'm here to take it. Okay, hearing none, we encourage Commission members to review and provide input up to September 25th. That way we can incorporate any of the edits ahead of the October 9th meeting and the circulation of the packet materials. Next slide. So this is the upcoming meeting schedule for 2026. Commission members should have received the calendar invitations for the Universal Healthcare Commission meetings. Please reach out if that's not the case. If you're interested in also receiving the FTAC calendar invites, you can reach out and we'll send you those as well. Next slide. So as the Commission is aware, we have an open seat on FTAC that was vacated by David DiGiuseppe. The current FTAC charter notes that all vacancies will be filled by the Commission. This is the exact language on the screen here. And staff are requesting that we add some additional information to the charter regarding the process for filling these vacancies and the criteria to review candidates. So next slide. This is the proposed added language for that process, and I'll just kind of pause here so folks can read through it. One thing I want to note is that second paragraph that talks about the 3 dedicated positions and how we define consumer representative. those are pulled from the original FTAC establishment process back in 2022. And so this is just kind of codifying it into the charter. So when we fill seats, we have this information all in one place. So I'll pause and let everyone get a read on this.
Just one quick note here. Thank you, Ally. Would love to hear either today or through any future comments that folks have. I believe it's part of that first sentence that describes how staff will circulate the vacancy announcement. And we note that we do it through our Gov delivery channels, but would love to hear if folks have other communication channels that they think would be beneficial for us to incorporate into this process, just to ensure that we're reaching out to as many folks as possible just to get the best candidates we can. So would love to hear if folks have any other channels that you think we should be using here. Thank you, Ellie.
Thank you, Ross. And if there's any edits, including additional channels or any discussion or questions on this, we can have that conversation now too.
Hi, this is Joan. I was just going to say I appreciate the inclusion in that first sentence of the commission will be delivered through the commission and the FTAC of delivery channels. Obviously, happy to use our distribution networks and our navigator sister networks and our CBO channels through the exchange as well. So appreciate that inclusion. And I read it. I like the additions and just from a process perspective, and I appreciated the inclusion of the expectation that commission members sort of circulate it to their networks as well, just to expand our reach a bit.
Fabulous. Thank you so much, Joan.
And just a couple of thoughts. I think it's perfectly appropriate, Ross, to try to get more circulation around vacancy announcements is to embed in the Gov delivery notice that folks should feel free to share it out with, like Joan said, their networks, et cetera, to try to get the broadest reach for folks that might be interested. And then on the consumer representative, I guess my only question, given how many of the folks who testified today on behalf of Whole Washington, WACAN, are like retired health professionals, should we be saying that healthcare industry professionals? I'm trying to figure out whether there's any room for folks who are no longer actively practicing as a healthcare professional being able to represent consumers. I'm just throwing that out there.
Yeah, Jane, I actually had a similar reaction. Like we have retired healthcare professional on the exchange board, and I understand wanting to avoid the conflict, potential conflict of interest, and also lots of good, engaged, thoughtful, folks who have been part of our health system for several years who we wouldn't necessarily want to include, I wouldn't think.
For example, Eileen Cody is a consumer representative on the Healthcare Cost Transparency Board, and she's a retired nurse. So just something to consider. I think the rest of the text is great.
That's a point well taken. Thank you, Jane. And I'll note too, for these 3 dedicated FTAC positions, they are currently filled. So those are not what there is an opening for, but we can definitely incorporate that into the language moving forward in case it does become open, that we keep that in mind too. Thank you.
You're welcome.
Yeah. Yes, I just wanted to confirm my understanding that the consumer representative also has to have the subject matter expertise in healthcare financing and those. Okay, great. Thank you.
All right. Any other discussion on the proposed language? And if not, I'd like to entertain a motion to approve the language with the discussed changes?
So
To
moved.
approve.
Second.
All right. We have a motion and a second. All those in favor say aye.
Aye.
Aye. Aye.
Any opposed, say nay. Motion approved. Thank you. Are we at 3:00? Oh, we're perfectly on time. What the heck? Next is we are going to discuss the Section 1333 Interstate Compact. During the June meeting, Commissioner Cooter requested we learn more about these compacts and hold a discussion on potential opportunities. Is the commissioner here?
Actually,
Is she?
I
Jane?
think the commissioner is trying to log on and is having a bit of trouble. So, Allie, can somebody send
We're
she
going to
and
take
Elise?
a 5-minute break and get the commissioner on. How's that?
That's
And
great.
staff will help her. All right.
Thank you.
All right, everybody come back at 3:05. I'll make sure my your camera or your audio's on. Sure it's on. Happened.
All right. Returning from our short break, and now we'll be transitioning to a discussion of Section 1333 compacts. And we're lucky today to be joined by Commissioner Cooterer to give us a brief overview. And so I'll hand it over to Commissioner Cooterer for some remarks. Thank you.
Thank you. Thank you so much. And hello, everyone. It's a pleasure to be here. I wanted to talk about Section 1333. This is from the ACA. It allows for healthcare choice compacts where two or more states create a regulatory framework to sell qualified health plans across state lines. Now, previously, we thought of this as a race to the bottom, meaning that the state with fewer consumer protections could potentially have their plans sold in our state. And if we had agreed to form a compact. And so this wasn't a very popular idea, but given that the federal landscape has changed considerably, it's forcing us to rethink how we do things. And what can we do in today's climate to help people get insurance, health insurance? And I think that, reimagining the 1333 compact is what we're here to hear about today. And I'm hearing from legislators who want to know about new ideas. And when I brought up the concept of compacts before, they want to know more. So I'm grateful to Randy and Jason for joining us today and giving us an overview of how the 1333 compacts work. And I think that this is a very valuable conversation for the commission to have because we do know that a Section 1333 compact to sell qualified health plans would require authorization from our state legislature and ultimately be approved by the federal government. So these are the very beginning steps, to say the very least. But even though we have our work cut out for us, I'm very eager to have this conversation, and I hope you all find it as beneficial as I know I will. And with that, I'll turn it over to Jason and Randy. Thank you so much.
Thank you, Commissioner, and good afternoon, everyone. It is great to be with you. I am Jason Levitas, and I'm a senior fellow at the Urban Institute in Washington, D.C. Let me give you a little bit of my history. I've been working on the ACA since the beginning. I served at the U.S. Treasury Department for the duration of the Obama administration, worked on the ACA legislative process, and then went on to lead implementation of the ACA at Treasury, which meant all the tax provisions and also 1332 waivers, which we'll talk a little bit about, and which have some similarities with Section 1333. Since 2017, I have been doing a lot of technical assistance for states through a group called State Health and Value Strategies. And you can go to the next slide, please. I think there's a slide on State Health and Value Strategies. There we are. And State Health and Value Strategies is a program run out of Princeton University, funded by the Robert Wood Johnson Foundation. And we provide technical assistance to state healthcare officials. We've worked with many of you, and you all are great to work with. I've done a lot of work through there on 1332. In none of these capacities have I done much work yet on 1333. Indeed, no one has really done any work on 1333, but it's exciting to think about it and think about what it might do for Washington or other states. Next slide, please. And Urban Institute, next slide again. Okay, so let's talk about what we're going to talk about today. So we're going to consider Section 1333 compacts as a potential tool for meeting the goals of the Washington Universal Healthcare Commission. Section 1333 is among several flexibilities within the ACA, and we'll talk about what the others are just for context. Section 1333, as the Commissioner said, allows states to enter into an agreement, a compact, to permit the sale of insurance across state lines, subject to several restrictions. CMS has never promulgated regulations implementing Section 1333, and no state has attempted to use it yet. However, as you know, current societal leadership has expressed strong interest in Section 1333 and appears to be moving towards implementation. Just to briefly summarize my thoughts, and then we'll go into it in detail, Section 1333 compact could potentially be part of a package of reforms to help move towards universal coverage. But there's great uncertainty about how Section 1333 will be implemented, which attaches risk to pursuing the program. And then I think even if it were implemented under a straightforward interpretation, and one might even say under any reasonable interpretation, Section 1333 has substantial shortcomings as a tool for pursuing universal coverage. But we can get into that as we go along. Next slide, please. Okay, this is all the things we're going to talk about. I'm going to give a little background on the various flexibilities on Section 1333 in the statute, its history, how it compares to the other flexibilities, and then considerations for Washington using it. Next slide. Okay, so here we're just going to talk about all the different, we have a little bit of number stew here, all the different sections of the ACA that create flexibility. Some of this is probably familiar to many of you, so I'll go through it quickly. So there's Section 1331, creates the Basic Health Program. It's actually based on a program that existed in Washington State before the ACA was around. You all have not done it. Your neighbor to the south, Oregon, recently did implement it. For a long time, New York and Minnesota were the only states that had them. Washington, D.C. has also moved in that direction. Basically, it's a way to replace marketplace coverage for some relatively low-income people with more of a Medicaid-like program, and then the state receives funding in place of the premium tax credit to cover those folks. Next, 1332. I could talk about 1332 all day, but I would guess you're familiar with it. Joan could also talk about Section 1332 all day, but it allows states to waive or modify certain specific ACA coverage provisions, many of sort of the central marketplace-related provisions of the ACA. Waivers have to satisfy 4 statutory guardrails. If the waiver creates federal savings by reducing marketplace subsidies, states can receive that amount as pass-through funding. It's discretionary. HHS and Treasury may, but are never required to approve a waiver. More than 20 states have been granted 1332 waivers, but the vast majority of them, including Oregon's, just support reinsurance programs. A few, including Washington's, achieve other goals. And this is something we'll talk about in the 1333 context. 1332, one of the guardrails is deficit neutrality, which says that no waiver can increase federal deficits, and that's been a barrier to using it as a tool to expand coverage. Next slide, please. Okay, next we have Section 1311 F1, which provides for interstate exchanges. This is sort of everything we know about it, is just the statutory language. An exchange may operate in more than one state if each state permits such operation, the Secretary approves it. None of them have been established, so there's nothing to say there. Next, we have multi-state plans. This required the Federal Office of Personnel Management to contract with some private insurers to offer marketplace coverage nationwide. We stood this up in the early days, but no issuers wanted to participate, and so it went away. And then finally, our subject today, Section 1333, Healthcare Choice Compacts, authorize states to enter agreements to permit the sale of health insurance across state lines, subject to certain restrictions. None have been established. There's no implementation guidance yet, but we think it may be coming. Okay, so let's get into that. Next slide, please. Okay, so the statutory provisions of Section 1333, which again is all we know right now because there are no regulations or other guidance implementing it. So it permits 2 or more states to enter into a compact under which a health plan licensed in one state can be offered in the marketplace in all the states in the compact. Such plans are generally subject only to the laws and regulations of the state in which the plan was issued. However, there are some exceptions. The plan is subject to the rules on market conduct, network adequacy, consumer protection, and rating from the enrollee's state of residence. The plan must be either licensed in each state or, probably more practically, submit to each state's jurisdiction for purposes of those protections listed in the bullet immediately above. And then the issuer must notify consumers clearly that the policy may not be subject to all the rules of the state where the consumer resides. Compacts must also, under the statute, satisfy 5 statutory guardrails. That includes the 4 guardrails from 1332, that they cannot reduce coverage, reduce the affordability coverage, or reduce the comprehensiveness of coverage, and they can't increase federal deficits. And then there's one more: they can't weaken the enforcement of the state rules listed in that first sub-bullet above. Next slide. Section 1333, unlike Section 1332, includes no language to waive other ACA provisions or to provide federal funding. So that's important. Like 1332, it's subject to federal discretion. HHS may, but is not required to approve a compact. There is a statutory role for NAIC. CMS must issue regulations in consultation with NAIC. And then, as with 1332, there must be state legislation that specifically authorizes the state to enter into an agreement. Now, one final thing, and this is important when we get to the statutory interpretation, the concept of interstate compacts appears in the Constitution, which provide that states may not enter into interstate compacts without the consent of Congress. The Supreme Court has long interpreted this to mean that congressional consent is required for compacts that abridge federal authority, which these do to some extent, in that generally under the ACA, a plan must be licensed in the state where it is offered, to be offered in the marketplace. And of course, 1333 says in this case, if it can be licensed in another state and still be offered. So this does sort of fit under that requirement. And I think that in many cases, 1333 has been interpreted to say Congress is giving their consent here that a plan that is offered in another state can be offered subject to these compacts if the compact is agreed to. Okay, next slide, please. Okay, so what is the history in the state of play with Section 1333? Again, CMS has issued no regulations implementing it, and no state has sought to enter one. In 2019, when Randy ran CSIO, and you'll hear from him next, there was an RFI that went out seeking comment, and there were comments collected. Another important fact, the current head of CSIO, Peter Nelson, published a piece last year highlighting opportunities created by Section 1333 and arguing for expansive interpretations of its authority. I know Peter has also been speaking about this at public meetings and is excited about it, and I think it made clear that they're going to move forward with implementation. And then CMS also recently requested the required consultation with NAIC that is necessary as part of the rulemaking process. Next slide. Okay, so there is a lot of uncertainty about 1333 implementation, in large part because, well, there's no guidance on it, and also we've never seen it happen. So let's just say, talk about what some of the uncertainty is. So there's uncertainty about the legal interpretation and rulemaking. How will the guardrails be interpreted? How might they interact with 1332 waivers, which is a focus of Peter Nelson's paper on the subject? The scope of authority to depart from federal rules. There are procedural questions. How does the application process work? What goes in the application? What's the timeline? Is there public notice comment? There's a fair bit of specificity in Section 1332 about that process and a lot less in Section 1333. What does monitoring and oversight look like? Again, we don't know. And then, how would the discretion that CMS has over Section 1333 be exercised? Next slide. Okay, so given all of that uncertainty, I've sort of, taken a shot at saying, well, let's say that CMS implements Section 1333 using sort of a fairly straightforward approach, sort of sticks to the statute here. What might that look like, and how might that play out for Washington? So under a straightforward interpretation, compacts could share risk with another state. They wouldn't permit other changes to federal rules, say to the premium tax credit or to other market reforms. The guardrail interpretations, let's say, might be similar to those under Section 1332. That seems reasonable. And let's say that the procedures for applying for approval and monitoring are similar to those under 1332. So what would that mean for Washington, for the goals of your commission? Well, so it could permit Washington to benefit from an expanded risk pool, right? So let's say you got together, just for example, with Oregon, and you said, we're going to create a compact and plans can be sold in these two states. Well, now with Oregon, you have a combined risk pool. Having a combined risk pool can be helpful to attract more issuers. It can help to stabilize premiums, potentially improve the risk pool. It could potentially also be used in concert with an interstate exchange that I mentioned earlier. In that case, multiple states could share both a single marketplace and a single set of plans, which would sort of create a nicely consistent consumer experience across multiple states. It would also potentially permit the sale of plans in Washington that do not meet all the state's requirements if it was the other state or states in the compact whose insurance market rules generally applied. So that would be something to be aware of. Or if it was licensed in Washington, then the plans might not meet the rules of the other states in the compact. It would certainly require extensive coordination with other compact states. And really, I should have added here, as Joan could tell you, it would require extensive coordination with the federal government as well for satisfying all of the guardrails and all the coordination that goes into the application and implementation process. It would not, and here we sort of get to what are the goals of your commission. It would not on its own expand coverage or streamline payment systems in any way. Even if it did reduce the premiums in your marketplace to some extent, as was sort of discussed earlier in the discussion of silver loading, for most people, especially low-income people, the premium they pay is driven not by the premium that issuers submit and that is approved. It's driven by the affordability of the PTC. Indeed, in some cases, higher list premiums can lead to lower net premiums that people pay. So we wouldn't expect this to have a big impact on coverage. For people ineligible for the premium tax credit, it potentially could moderately reduce premiums. Okay, so I think that's and then in terms of sort of broader goals of providing funding to increase your state subsidies, it wouldn't sort of do any of that or other things you might do to expand coverage, which generally costs money, as you know. Okay, and then I think this is my last slide. Oh no, I have two more. Let's see. Okay, outstanding. So outstanding questions under a straightforward interpretation. We even if it was similar to 1332, there would be a lot of specifics about sort of procedural questions, the rules of coordination with 1332, the exercise of federal discretion. I mean, I think under any interpretation of 1333, I think, the question for you all is, do you think that, CMS as currently constituted would be likely to approve a waiver or a compact that, had the goal of expanding coverage, given some of the preferences we've seen in their other policy actions? Rules for reconsideration and termination. We don't know what those are, and that's important in these discretionary programs because, as Washington, D.C. goes back and forth between the parties, there is a lot of some ping-ponging that occurs as we are seeing right now, and so it would be sort of important to know how subject you would be to the whims of future administrations. And then, of course, there are just the market outcome questions. Would issuers, in fact, participate? Would premiums, in fact, fall? Would consumers enroll? And that's sort of always the question when you try a new program like this. Okay, and now my last slide for real. Considerations under exam interpretation. So I know Randy is going to focus on this more, so I will just say a little bit. I think if you read Peter Nelson's paper, he has a vision for the implementation of Section 1333 that is much more expansive, that sort of ascribes to it many of the authorities that are explicitly in 1332 to waive additional ACA provisions, to provide pass-through funding of sort, to be immune from federal reconsideration. I think that those, just legally, that interpretation is quite outlandish, but, a lot of outlandish, legally outlandish things are happening right now in the country. So I think it's certainly worth considering that as a possible path forward. I think if that did happen, what would be the thing? Well, again, you would want to be thinking about the exercise of discretion, that even if the government was wanted to use this as a tool for flexibility in some cases, would they want to consider the kind of flexibility that you want? There would certainly be the litigation risk given the challenges of this interpretation legally, although again, who knows what the courts would do. And then I think, the deficit neutrality guardrail, again, if that was interpreted similarly to the one under 1332, it would likely still be a bar to, even if 1333 could be interpreted to provide pass-through funding, if that pass-through funding was subject to deficit neutrality, it sort of wouldn't add any money to the mix in Washington, which could be a challenge, create challenges for using it to expand coverage. So with that, I will stop, and I'm happy to take questions now, or if Randy wants to go next, we can take questions together, however you all want to do it.
Thank you, Jason. I think our plan is to take questions at the end. And so we'll be happy to call on folks at that time. And next we'll turn it to Randy Pate, who's previous director for the Center for Consumer Information Insurance Oversight and currently with StatesWork. Thank you, Randy. Please go ahead.
Yep, thank you. Appreciate it. Yeah, Jason did a great job of walking through some of the legal details. I have a little bit of different take on some of the positions that he's sort of staking out. I would say not necessarily going, as far as maybe my friend and colleague Peter Nelson would do in his paper, but wanted to walk through, just some of the same issues, maybe from a little different perspective. Of course, like you just said, I was the director of CCIO during the first Trump administration. We actually approved 16, 1332 waivers around the country. Most all of them were reinsurance waivers, but those did expand coverage and improve affordability in those state markets. So just want to walk through. Maybe we can go to the next slide, please. In addition to my sort of day job as a consultant in private practice, I've started StatesWork a few years ago. To really kind of support states in the technical assistance side of some of the waivers and some of the discussions that you all have in terms of improving coverage, affordability, and access in your states. Next slide, please. So Jason really set the table really well for this. I will just say that when we were there, we did issue a public comment and a request for public comments in the Federal Register, and I think we got maybe a couple of responses, from different states. The idea was that, obviously back in 2017, 2018, states were experiencing massive affordability crisis with the premiums jumping by double digits every year, and so states were looking for answers. I think more states leaned into the 1332 pathway, obviously, but I think it is something that we thought the 1333 option is there in the law, and let's see if we can possibly use it to try to help some of these markets. Next slide, please. So this is going a little bit into Peter's thesis on the law, and I think. I don't think it's outlandish. I do think it's supportable. Again, I would say I'm not personally as probably certain, and I think all this is pretty uncertain actually because it's never been tested or used before. But
the point that one of the points that Peter made in his paper is this idea of regulatory stability, meaning that if you look at 1332 waivers, for example, they're 5 years, they have to be renewed. And, you know, in theory, you know, once you get one and you sort of continue to meet the guardrails, you should be okay. But, you know, as we saw during the previous administration with the Georgia waiver, you know, a waiver was approved, the state appropriated $100 million for reinsurance. And, you know, the Biden administration sort of decided, no, we don't like this one part of your waiver, and suspended it. So, you know, which I think, you know, has a chilling effect, you know, potentially on state innovation. So one idea would be, you know, under a compact, which is, you know, again, recognized under the Constitution, like Jason said, you know, could a state get some more longevity and possibly stability with this, you know, swapping back and forth between the parties and the different regulatory schemes. So, for example, let's say you really loved the 2017 market stabilization rule. You could, you know, sort of take those policies, put those into place in your state, in theory, and then have them apply even when another administration comes in and says, no, we hate that rule. We want to, you know, we want to do something different. So the structure, again, you know, is sort of aligned, I think, like Jason said, to affordability and maybe reducing barriers to access when you have multiple states involved, and barriers to competition in the market. So maybe jump into a little bit of that. Next slide, please. So I try to think about it in terms of CMS and what types of regulatory approaches they might take. And this really could be in any administration, but Republican or Democrat. But, you know, you could see a couple of different approaches. One would be, you know, just sort of a minimalist approach, sort of codify the statute and regulation, and then just see what you get from states, and, you know, and see if you approve it, and see if it can sort of work. You know, another way to do it would be, you know, come up with a completely different program, and, you know, a completely different idea, and submit it and see, you know, if you can get that approved. And then there's sort of the mix and match between the federal and state regulation. Next slide, please. So again, these are the guardrails. You know, I think the one that is particularly challenging to me is that federal deficit guardrail, in terms of, you know, thinking about something like a universal health care or single payer or something like that. And then even really in general for any waiver or compact like this, you know, how do you ensure that the federal deficit guardrail is being met every year? Or do you do it over some period of time? You know, do you say, okay, we're going to measure this over 3 or 5 years? And that's actually a you know, challenge in the 1332 context as well, is, you know, how do you really calculate and measure federal deficit neutrality? In other words, let's say you make investments as a state in something, in a program that, you know, has upfront costs, but then can show savings later. That is even, you know, been proven difficult, you know, under the interpretation of the guardrail in 1332. I think probably the same thing would happen under 1333, but maybe even more, you know, difficult because of this potential for, you know, it being indefinite. Next slide. So, I mean, we kind of talked about what CMS could do a little bit, but, you know, you might get something that's very prescriptive and robust, you know, from CMS. You might get not much at all. The other thing you could see, and this is something that we did when I was there, which is sort of put out, you know, these are fast track options. If you're a state or states and you have ideas that are along these lines, you know, these could be fast tracked for approval. Next slide, please. So, and then on the state side, you know, thinking from your all's perspective, you and Jason really, I think, did a good job on this, but, you have to sort of think about what would you like to keep in terms of a federal standard or federal program. I think about risk adjustment, as something that could be potentially very complicated and difficult under a 1333 compact. The federal government is doing it for every state right now and sort of sets the policy for it. What would that look like, under, a real, substantive type of 1333 compact? And so, and again, administrative capacity, all these things I think you're probably familiar with, especially states that have had 1332 waivers, like Washington State. And, I just thought about, well, maybe there's some sort of transitional approach you could do in a partnership with the federal government, to sort of get there and surmount some of these challenges. Next slide. So I also try to get a little bit creative on, what states could do in terms of how they would set up something like this. And I call it regulatory headquarters, but it's really more like a commission. So maybe you had 2 adjoining states, or they don't have to be contiguous, but you would sort of set up, okay, here's our single streamlined set of regulations, and we have a commission or commissioner that sort of oversees this and make sure that everything's consistent across states, and also I think the state underlying regulations are being followed to the extent that that's agreed to. Of course, states have different regulations, very, very different postures in the market, and that that is that's across party lines. Even there are states that are very red states that have stronger consumer protections in some ways, and then there are blue states that have more issuer friendly regulations. And so that is a big challenge in sort of coming together to meet on a series of regulations that would apply across both. And then of course, market conduct, network adequacy. Jason mentioned all that. And I think contiguous states obviously do kind of make more sense in one point of view, and especially if you happen to be aligned on your sort of political leanings and so on. But it really doesn't have to be that way. You could have states that are across the country and not at all geographically connected be part of a compact in theory. Next slide, please. And this is sort of the checklist again for, at least without any regulations issued from the federal government, what a state would need to do. You need to have authorizing legislation that gives you authority. You have to have your actual compact package, and then I thought about you'd also probably need to have some sort of mechanism for future adjustments without having to go back to the federal government, and that would all have to be approved, I think, up front. And then, like Jason said, the litigation issue, I think, is a real one. And of course, we don't have any regulations yet. Next slide. I think, pretty self-evident. I would just say, if you did have concrete ideas for a compact, I think early engagement with CMS is always a good idea. And, I think the team is great to work with, and, is always open to discussion. Hopefully everybody, on this call that's dealt with them has had that experience, kind of regardless of where you're coming from. But next slide, please. And that's it. Thank you.
Thank you so much, Jason and Randy. Just want to mention, normally when we meet with our presenters and ask for these, we have some direction to give folks, but there was not so much information on 1333. So just really impressed and appreciative of all this information you gathered and put together to kind of inform the commission. So just wanted to say a special thank you to Jason and Randy for those great presentations. And now we're going to transition into questions. Audrey, I believe the next slide has a few prompts on there. that we can begin with, and then also open it up to commission members for any additional questions that they have. But just to get the discussion started, I will lead off with this first. Jane, is there anything you'd like to say before we hop into the first question?
Yeah. So, and Jason and Randy both know me. You guys all do. So I'm sitting, thank you so much for these presentations, super helpful. So I'm sitting and I'm thinking about what could you do with this, right? So Jason, for example, you talked about a multi-state exchange. And let's just use Oregon as an example. I just want to say we have had no discussions with Oregon, but I'm just trying to make this concrete. So Oregon just adopted a basic health plan. In Washington state, we've had discussions for years about BHP. And the concern has always been if you pull the up to 200% population out of the risk pool that's left in the exchange is too small for market stability. Well, could you have conceivably under 1333, could you have multiple states that come together that decide to do a joint BHP, which then means that the risk pool, the number of people in the individual market that are above 200% of poverty is significantly bigger because now you've got multiple states participating. So that's one. And then number two, state-based exchanges currently can add qualified health plan certification requirements. And this commission has had many, many discussions about whether there are opportunities for administrative simplification, right? Can we standardize the way prior auth is done, right? All of these issues to try to simplify administration and save money that way. Could you use a 1333 compact to have multi-state agreements around QHP certification criteria that would give you an opportunity to almost like pilot or test approaches to administrative simplification? So that's my question to Jason and Randy.
Okay, I'm happy to take a shot at both of those. So in terms of doing it with the BHP, yes, I mean, again, we haven't seen any regulations, but I do think that could be done. I mean, I think it's worth noting that Minnesota, which I think probably has a smaller population than Washington, has had a BHP for years and hasn't had any trouble, keeping its market going with sort of the part that's remaining there. So I'm not sure it's crucial to join forces with Oregon to have a big enough individual market remaining. But I think it would certainly do that. I think the question there would be, it's a lot of effort, and I'll get to that in the second, answering your second question. And is it worth the effort of standing up, as Randy said, you might need some sort of like interstate commission, and doing all of that to get this merger of the markets, which again, if the goal is to expand health coverage, how is it leading to that goal? To your second question, about using this as an opportunity for innovation. I mean, to me, and this again goes to like what this would look like sort of operationally and procedurally working with another state, right? And I defer to you on that, but when you join forces with another state to make these decisions, I guess the question is, do you sort of replace the state's existing administrative apparatuses with this one combined one, and then maybe you get some economies of scale, or is it more like you're layering this new thing? I'm thinking of like the transit authority in New York State, where it's like, this joint interstate thing, and like, does it actually end up being simpler and more streamlined to get things done with this additional authority that sits on top of all the existing establishments, or does it not? And I sort of can't answer that question for you. It depends on how you'd set it up and your relationships with the other state. But I don't, it's, to me, it doesn't seem automatic that things would be simpler and more flexible using this type of approach.
Yeah,
Thank you. Oh, go ahead, Randy.
Oh,
Apologies.
sorry. I would just, I mean, I guess I have a little bit of a difference of opinion on that, and on this particular idea, because, you know, I mean, and first of all, you wouldn't necessarily have to do a joint BHP. You could do separate basic health plans in each state, and then have the compact over the top for your, you know, your residual individual market. You know, I can see how, while it's true you may have a viable market, you may not have a thriving, you know, you may not have a lot of, it may not be super attractive to competitors to come into the market, which, you know, I mean, does help to lower the premiums and make, you know, increases the choice and the options. So, you know, from that perspective, I think, you know, that could be helpful, and to have a single set of regulations right across, which makes it easier for insurance companies to file products and get them approved.
Thank you. Thank you, Jane, for the question. Thank you, Randy. Jason, Representative Schmick, if you'd like to ask.
Yeah, thank you. Okay, in your slides, Jason, you were showing how the state or any plan will have to follow the rules in their home state. And then they also have to follow the rules in the state that they're going into. So, but my guess is, and let's use Idaho as an example, my guess is plan design looks a whole lot different in one state to another. So is that, with that, I know there's no rules written out, that there's no guidance here. So my guess is, looking at your crystal ball, how would plan design go across state lines when we here in Washington, we may have a more a richer plan design than other states. Any guess on how that might work?
Yeah, it's a great question. I mean, I think that as CMS moves forward to implement this, they are likely to say, and I don't think this is an unreasonable reading of the statute, that most of the plan design rules can follow the rules in the issuing state. Now, of course, you would have to decide to agree to that, right? So you would, you know, are you okay with plans being sold in Washington that follow the plan design rules in Idaho or Oregon or wherever? But my guess is that's sort of part of the idea here, is you would continue to have your own rules for the Washington licensed plans, but then there also might be additional plans from other compact states that could be sold in Washington that would then follow the plan design rules of those states. But I'm curious if Randy agrees with that thinking.
Yeah, I do. And you know, it really harkens to the, you know, it was, gosh, 10 years ago or more, maybe, where there was the whole discussion about insurance across state lines, right? And so, for example, Georgia, and I think maybe Idaho, we may have the two states, they enacted legislation that basically said exactly that, which is, you know, if you have a health plan approved under another state's regulations, you can come in and automatically have it approved and be sold in our state. I don't think any carrier ever did that, and my assumption or my hunch was it was because they were really worried about ticking off the regulator in that other state. You know, in the higher regulation state, you know, you come from a very low regulation state, like let's say you pick an Idaho plan and you want to sell it in Georgia. Well, you know, it's not going to be a great relationship with those regulators, you know, in the long term, if you're sort of undermining their rules. But that was my theory.
Thank you for that question, Representative Schmick. Dr. Quanget, please go ahead.
Thank you. Thanks for the excellent presentations. I guess my question was similar to Representative Schmick's, and around, say, vaccine guidance. So say plans in Washington cover Washington's guidance for COVID-19 vaccine, and Idaho, of course, covers Idaho's guidance for COVID-19 vaccine. But the guidance between Idaho and Washington for COVID-19 vaccine differ. Could you please talk through how that would be dealt with?
Sure. Yeah, I think that and this is an area of great flux right now, but as a general matter, I think that benefit mandates, requirements for what is covered would be one of the things that would be subject to the compact, and so the rules of the licensing state would generally apply to the compact plans for things like that.
Thank you.
Thank you. Teresa, please go ahead.
Yeah, thanks so much, Jason and Randy. Appreciate your presentation. I have a couple of questions, but I'll start with I'm curious in our dealings as a state agency with CMS, they usually say, here's the process or here's the structure, and then you apply and you get it or you have some negotiations. I'm just curious, it seems like CMS is sort of asking states, hey, if you want to do this, come up with it, and we'll tell you if you're right or wrong, or we'll tell you how to manage it. And I'm just curious why they haven't come up with even an implementation framework or more than this. And maybe I've just missed it.
Well, I can take a stab at that. It is, well, partially there's the whole NAIC, consultation requirement. And I would also say, I guess that process is now beginning, but, had really not been undertaken. But I would also say, that approach, it's always available to CMS or any regulator to take the approach of we're basically just going to codify the statute and regulation, in other words, very minimal additional framework around it, and then see what you get. And that, I think that's fairly common for, especially when you're looking for states to come in or other entities with ideas. Jason, I don't know if you agree with this, but some of the initial regs on 1332 that came out were fairly, just sort of tacked pretty closely to the statute in a lot of areas, and then you tweak it later with guidance. But I don't know if you agree with that.
Yeah, I do. I think that is certainly possible. With 1332, by the time I was done in government, we had a pretty detailed set. It was partly regulations, it was partly guidance, which then later was codified in regulations. But I think Randy is right that if CMS wanted to be less specific, it could, and it could let states come in, and it'll just sort of be interesting to see. Peter Nelson's ideas about what 1333 can do, they are specific enough, and clearly are sort of not mentioned in the statute, whether or not you think that the statute could support them. That I guess I have been thinking that if that was the way he wanted to go, he would put some of that in regulations. But I think Randy is right. He could, in theory, not do that and then invite states to come in and sort of propose that themselves.
Thank you so much. Thank you for that question, Teresa. Senator Cleveland, please go ahead.
Thank you. I have a question around the marketplace and consumer experience and hopefully efficiency. Would plans offered under 1333 compact be offered on our Washington State Health Benefit Exchange, or would an interstate exchange be separate from our Washington Health Benefit Exchange? I know, Jason, your slide 36, you touched on this, and I just was interested in a little more clarification.
Sure. Yeah. Again, no one has done an interstate exchange, but the idea of it is that it would replace the state exchange.
Okay.
And that, right, instead of having your own exchange, there would be one interstate exchange that would cover Washington and another state. And then, yes, I think the idea is that the compact plans, whether you did an interstate exchange or not, the compact plans would be sold through the exchange.
But just to be clear, I do think you could do it with two separate exchanges and just literally have the QHPs sold, and that could be the only thing subject to the compact could be those certain qualified health plans.
Thank you so much. And I see Joan has her hand raised, and I'll note we are running a little behind schedule. So unless anyone else has other questions, we can end this after Joan. Joan, please go ahead.
Thanks. And yeah, hi, Randy. Hi, Jason. Randy, thanks for not, as the representative on behalf of the Washington Health Benefit Exchange, thanks for the option that doesn't destroy us. Appreciate that. I think with my question is a little bit, I have several, but yeah, I think you just answered my first one, so I'm just getting to the second one in the interest of time. But if, we've worked toward, in Washington, we've worked toward sort of standardization of our market. So, and we have no lack of plans. We have a lot of carriers and a lot of plans. So to me, this seems like a mechanism that would bring in more plans and then also bring in more plans that would make it hard to compare to our current plans because they'd be playing under a different set of rules. So just sort of wondering from a consumer experience perspective where we would see this as additive. I think I'm hearing that it would be like more choice potentially, especially in areas where maybe there were less options. But because we have such a robust market, I'm just looking for sort of the value add there in terms of volume. And then I think to some of the other comments that have been made, I'm curious where the savings, like where you all see this as like a states in this budget environment, just if there's an opportunity to use these waivers. It seems unless we would just sort of part and parcel say, you're in the compact, so I like Idaho as the example. So Idaho, you can offer your plans in Washington and customers can buy those plans in Washington and we'd sell them through the exchange. Where would the potential savings be to the state of Washington, assuming that we would still make all the Washington plans, do all the Washington regulations? Like, is there a savings opportunity there that we could leverage?
Yeah, and totally, it is a very, very difficult question. I think it's tough. So what you were saying just reminded me of another reason why you haven't really seen this in the past, even though there have been a couple of states that have enacted these across state lines laws. It's the networks, right? The network is, you're not going to import a network from another state. So I think of it in terms of risk pool. If you did want to broaden your risk pool, you're not necessarily, you're not necessarily saving money for everyone, but if you did have pockets where there just were not enough, folks in a service area or whatever, and you wanted to merge those risk pools, you could do that. But I mean, honestly, other than that, it's a challenging question, no doubt.
Thanks, Randy.
Joan, did you have anything else?
No, I just want to make sure. I have questions about we have a 1332 waiver, the intersection with the 1332 and the 1333 is sort of making my brain hurt because you have to meet the guardrails for the 1332. Then you'd have new guardrails that cross multiple states for the 1333. So we can do things within our own state to make sure we're meeting the guardrails for the 1332. And our state legislators, many of whom, several of whom are in this room, virtual room, have helped us do that, where to get the approval to expand coverage to allow everyone, sort of regardless of citizenship status, to come in and access care. We had to pass very specific state laws that said very specific things to get, and we leverage a little bit of state resource to be able to do that. So meeting the same 1332 guardrails plus that additional bonus one across state lines, when your risk pool, it does kind of get merged, and so you have less state levers to sort of help manage it. That's just one where I really appreciate the presentation. I just think, I don't know if you all have magic wands or solutions for that, but thinking about how those would go together makes my brain hurt, and that's why all of you have technical assistance jobs because we need you.
So Joan, do you see that as something that we want to have additional information or even conversations on? Or is it just
only
something
if
you
any-
need to work through your brain?
No, I mean, I was going to work it through my brain, and I
Yeah.
think to me it would be like if the commission felt like there was viability here or interest, then we would have to sort of piece it together with our existing waivers and
Yeah. And that's kind of the question before us, really. I see Mohammed has his hand up, and Mohammed, did you have like something you wanted to see additional information on, or?
Yes, Vicky, thank you. I just from the little that I read from Minnesota, I mean, uh, generally people say their health care delivery system is amazing, because a lot of they managed a way to cover most of their people, and for our universal healthcare ambitions, that is one of the things that we're trying to accomplish is cover all Washingtonians. So I would really like to see maybe if it's possible, like a comparison of how it improved accessibility in Minnesota and other states. And I don't know if that is 1333 or the other one, but yeah, just my thoughts around there.
Thank you. So additional information on the Minnesota healthcare system. And then Ross, I think we've hit question number 1 on here, right? We're trying to move on, but really want to think about, do we want to engage with Oregon about their interest? I'm not sure what Commissioner Cooter, she had to go. If that was something the OIC wanted to do when they were just asking us about it, or if they were, I know that we have limited staff time, so just trying to figure that out. And I know Jane has to leave in a few minutes. And then, yeah.
I mean, Vicky, really quick, I think that speaking for the commissioner, she would appreciate an opportunity to have a discussion with the folks from Oregon, just to see whether there are opportunities for alignment that sort of move in the direction of the principles that both states are talking about, knowing that this option would be limited to qualified health plans.
Right. And would that be her or her?
I mean, we're happy to help facilitate the discussion if you don't want to ask your staff to do it.
Well, they're technically not my staff. But
Well, HCA staff, you're right.
Yes.
Sorry, Vicky. You are the chair.
Well, and would be happy to kind of put that to the commission. That kind of speaks to more the second question that we have here. Would love, to know if there's any additional information or if folks are interested in having staff or, as Jane mentioned, OIC reach out to Oregon about their potential interest in 1333. And I see, Teresa, you have your hand up. Please go ahead.
Yeah, I would just say, I think one of the questions, Jane, your sort of offer brought up is that a OIC Commissioner Cooter to Oregon's counterpart conversation, or does that include the Healthcare Commission? And I think that's sort of what you were asking, Russ, a minute ago. Is that just a conversation that states to states can have without the commission, or is that something that the commission wants to be part of? And I think that's what your second question is.
Yes, yeah, would love to hear from folks if this is something that, as commission members, you'd like to move through the commission to kind of ask these questions, or if this is something that we'd like to have OIC lead on, and we can offer any support on. Nicole, yeah, please go ahead.
Hi. I would actually really love to be part of these conversations. It was something that I was looking into back in 2021, 22, and would love to learn more about the possibilities.
Okay. And not seeing other comments here, and given being short on time, perhaps we, Representative Schmick, please go ahead.
Thank you. The only thing I would say that if there's going to be discussions about this, where there also has to be a discussion about potential savings. I mean, because that's the whole purpose for this, is to more coverage at lower cost. And if we don't accomplish that, I don't know if we want to expend a lot of assets in doing that.
That's a great point. Jane, just one point of clarification. If that conversation, is that something that you wanted to have like at a commission meeting, or is this something that we would do and then report back on to the commission at a future meeting?
I think the latter.
Okay.
Great.
Well,
And then just remembering that Nicole's interested in being involved if she could.
okay.
Same with the exchange too. If it would impact how we're doing business in the state, would love to be part of it.
Excellent. Well, and given the time, perhaps staff can try and get a meeting scheduled and invite folks here on the commission. That would be, well, I guess we'll have to be mindful of OPMA rules. So we'll try to coordinate a meeting and make sure that we're staying in line with open public meeting requirements, and then plan on reporting back. And we'll give any updates if any of that changes in between now and the next commission meeting. Any objections, please let us know, and apologies for having to transition out of this quickly.
As Dave's stand-in, I support that.
Okay.
All right. Does anybody have any objection to that? I guess is the best way to round out the conversation, other than the making sure that we're looking at potential savings. All right. So we kind of blew past our break, so I'm glad we took one earlier. So next, we've got about 50 minutes to go through the FTAC update and a couple of decisions about some information that they need to continue their work. And then also some time to do the transitional solutions. So gonna pass it over to Ross to take us through the FTAC update.
Thank you, Vicki. Just a quick update from the last FTAC meeting. The last FTAC meeting was on July 17th, and 4 public comments were received. Members of the public requested that the Commission and FTAC consider addressing governance earlier. Requested they seek funding, Universal Commission seek funding for implementation of universal health care. Provide recommendations for future actuarial analysis, and express support for the Advocates Roundtable. Then FTAC reviewed and provided feedback on straw proposals for the key element designs, as well as eligibility and benefits and services, and then concluded the meeting with initial discussion on transitional solutions. And then moving quickly to straw proposals, we'll be going over very briefly today our 2 straw proposals, touching on eligibility and benefits and services. And just a quick note on straw proposal, we are kind of taking this from sister state Oregon and using these as sort of, these can be modified as the name implies as we continue to go, but really like this format in that it puts everything down in writing, intended to be easily understood and approachable for folks. So just wanting to signal that these can evolve and can continue to change as we move forward. So jumping quickly into the eligibility straw proposal, and if Audrey, if you could, thank you. Just very briefly, this proposal outlines recommendations for addressing eligibility and universal health care. Let's see. The ultimate recommendations that came out of this, well, let me make one quick note. The Commission, FTAC, and the work group identified populations that could potentially be eligible in a state-based universal healthcare coverage system, and we're aware that the federal budget passed in July, and this could affect availability and affordability, in noting that there may be some changes to modeling in the future based upon those. And so part of that is we identified the initial group of Washington residents likely to be eligible to be covered by a universal system. And I think that may be on the second page of this memo, and encourage folks to look over those and review those. also identified the federally excluded populations, Medicare, federal employee health plan benefits, and TRICARE. And then also went into a discussion of one of the trickier pieces of subject matter related to this work, which is the role of ERISA plans, fully insured and self-funded as it relates to being able to offer universal benefit. So we hope that there's a helpful discussion of that included in this as well. Also noting some limitations regarding American Indian and Alaskan Native Washington residents and residents without full rights of citizenship, and different approaches that could be taken when considering benefit design. And so just wanted to ask if commission members had any questions or edits that they'd like to propose for this specific straw proposal. Joan, please go ahead.
Yeah, thanks for putting thoughts to paper too. I think it is helpful to see. I'd sort of have a content and then a format-based question. From a content perspective, I was really curious either about the EPTAC discussion, or Jane, you might know off the top of your head what the small group ERISA exemption and the 1332 would have to do with each other. That was just sort of a piece that's in here that I have curiosity and questions about. And then from a kind of format, but kind of substantive perspective, in the way that we usually think about eligibility criteria at the exchange, you would sort of say, here's everyone who's eligible, and then here are the programs that, if they have this coverage, would sort of count as minimum essential coverage, or just sort of count as coverage that would sort of then pull them out. So it's curious to me how we're handling. I wasn't sure what the FTAC rationale was for pulling out people who are undocumented and handling them as a separate and discrete group, as opposed to just saying all Washington residents are in, and then people who have these coverage types would sort of continue with those existing coverage types. Like, I sort of assumed we'd start with everyone and then funnel out to the coverage types that maybe we would consider as substitutes, but that as a baseline premise, everyone would sort of, I thought we were sort of starting from an inclusive place. So I didn't know quite what the rationale was for pulling out sort of people based on status as part of the exercise that was put in front of us.
Thank you, Joan. Would happily defer to any of our work group members if they would like to provide any comments related to Joan's questions.
Hi, this is Eddie. So I wasn't exactly sure when you were saying why were the ERISA plans different than the rest?
Oh, no, I understand why they're different. I see in the chart, it says potential pathways to eligibility for the small group market plans not subject to the ERISA preemption rule, section 1332 waiver. And
Yes.
Since we hold the 1332 waiver, I was like, tell me more, since I
Oh,
wasn't
it's like
quite
doing
sure
a
what was
show.
envisioned.
Yeah, the distinction, I think Jane you could probably answer that quickly.
That's where I was like, Jane might know. Yeah.
Yeah.
Yeah, I have to unmute myself. It's a matter, Joan, right? You could do it because the ACA applies to individual and small group, right? EHB, et cetera, et cetera, et cetera. The question that came up was, how much would, in doing this, we might need to alter ACA provisions, right? So for either the individual market or the small group market, both of which are subject to the EHB benefit, right, benchmark plan, et cetera, are there modifications to ACA rules that somebody would want to make in a universal healthcare system that would end up requiring a 1332 waiver, to the extent that those changes were things that were waivable under 1332? Does that make sense?
I'll find you. I'm just not quite, I think I'm missing it, Jane. I'm clicking to what's the waivable provision that you could touch with the 1332 that would get the the some of the other plans in there, but I get I think I get the concept. So thanks.
Right. I mean, the question is, if in the vision of eligibility, et cetera, are there ACA provisions that would need to be waived?
Yep.
And if those are provisions that are waivable under 1332, then it brings in consideration of a 1332. Does that help?
Totally agreed. I wasn't sure if
Okay.
there was one we were gunning for as it relates to ERISA.
No, I think-
was like, I don't know if they're
No.
waivable.
Well, yeah, I mean, the whole this ties in to the financing question, right? If you do a
Yep.
pay or play mechanism, any plan that's subject to ERISA could end up in a pay or play mechanism saying it's more advantage for me to pay, right, or to play than it is to stay outside of the system. So it's sort of two different concepts that interrelate.
Thanks.
Because once again, nothing about healthcare is simple.
Did that
And then,
answer?
Eddie, I wasn't sure if you had thoughts on the second piece either. Also, the sort of thoughts around pulling out folks based on status. I didn't know if maybe there was a regulatory, just sort of what the rationale is there.
No, I think that was it.
Thank you, all. Not seeing any other questions at this time, I will send it to Vicky for a vote.
Thank you.
Vicky, sorry, can I just ask one more thing?
yes,
Given that
please,
there are
Joan.
changes potentially we'd want to see to this document, what
Mhm.
are we voting on? Are we voting to have a document that then gets changed again, or is
Right.
or are we returning for revision and then it comes back to us and we vote?
I think this document will be going back and forth between us and FTAC. So, yeah, voting to move it forward. Is there specific changes we want to see before it goes to FTAC? But then always understanding that we're not putting anything in stone. This is like a straw poll, basically not made of bricks, but straw. So something that just to move forward, FTAC needs like more information to do their work. So this would go to them and then come back to us. So is there something specific you want changed before it goes to FTAC, I guess is the question. Do you need that part about the immigration status? Do you feel uncomfortable with that, Joan? And I see Rep. Schmick has his hand up.
I'm just gonna, I think Joan's got some good questions here. What is the purpose for sending it back? This is a draft. It's not a final document. Are you just looking for input today to give further guidance? I guess that's my clarification, please.
I think
Great.
if I could,
Oh.
think if I could jump in, this
Please.
is all iterative,
Mhm.
right? Representative Schmick, it's like, if we want to talk about how providers are paid, if we want to talk about what the system would cost, it's like an iterative process of, well, if this is the population that you're talking about covering, then this is how it would influence additional discussions around what you want to pay providers and how you want to cost out the system. And so, and that additional level of analysis could conceivably end up bringing questions back to the commission about whether there are things that the commission might want to change about its initial thoughts on eligibility. But it's sort of giving them a baseline to work from as they do the next step that the commission asks the FTAC to undertake. Hopefully that helps.
And also a clarification on my part that this will go into the report and it will be noted in the report that this is just our thinking right now and that it might change as the work moves forward.
Yes, that was one of the considerations, was a motion to adopt to incorporate in the legislative report, and defer to you, Vicky, certainly. But given the comments and questions, it unclear whether the commission would like to incorporate this into the report. So maybe that would be the most appropriate question to ask at this point, of whether there's interest in incorporating the straw proposal, acknowledging that it's not in a final format, but that it would be expressing the current perspective of the commission on these specific issues. If they would like to include that in the legislative report, or they'd prefer to further refine before including it in a legislative report.
From my perspective, it'd be great to further refine it before it went in the new legislative report.
All right. Any other comments? Mohammed?
Yeah, I would also like to see, I don't know if it's possible, but the exclusions spelled out. Before we add it to the report, who is covered, and the goal here is to cover everybody in Washington. So if this draft is spelling out some exclusions, for example, as John said, due to documentation or things like that, I would like to see that before I'm comfortable voting on it. I don't know if that makes sense.
Mohammed, there is a list of folks who would be excluded under federal due to a federal conflict. Could you just specify what other groups you're referring to regarding exclusions?
Just that. I know that there's the federal part of it, and there's a waiver. But if I guess what I'm trying to say is, I would be more comfortable to assume that what we're working on is something that basically covers all Washingtons with no exclusions that we can avoid right now.
Okay. So we will take this back, and I try and review the questions and comments that we received today, and may potentially work with the work group to make some updates to this document and bring it back to the commission. So thank you.
Happy to share two thoughts. It's in writing too. I can follow up outside of this. I think for me, where the disconnect is happening is that we have a document that's oriented by coverage type. And then we have two groups that we call out specifically based on status, AIAN, which to me makes sense given the government to government relationship there, and Vicky, defer to you and others. And then people who are, and then the immigrant population. And we have immigrant populations who are covered today through various mechanisms, through a lot of the coverage types that are listed above, through Medicaid and CHIP and individual health plans, and who are also represented in the uninsured bucket. So for me, the question is is there a rationale for pulling them out that would be different than any other group? And if not, then I would just integrate everybody into the same coverage type bucket.
I can respond about the American Indian Alaskan Native.
Yeah, I assume AIAN, Vicky, was pulled out for the government to government relation. It makes sense that's called out to me. The people without full citizenship, it's not as intuitive to me why that group would be called out.
Right. Do you want me to respond or?
Oh,
go ahead. I think I get the AIAN part if we're short on time. I just didn't. It's the other one that is puzzling to me.
Yes, I can't respond to that one as well, but we need to honor the Indian healthcare delivery system. So it's important that there's informed consent when an American Indian Alaska Native is opting into other coverage.
Yeah, that one totally makes sense to me.
And thank you, Joan, for articulating that question. And that's something that we can bring back. And thank you also just for sharing your concerns in general. We don't want to get out ahead of ourselves here. So thank you.
Yeah, and we're just kind of whispering over here. I'm sorry, I had my mic on too, but maybe just bring it back in October. It won't get into the report and because we're voting on the report that day, but maybe something that can be an appendix if people feel strongly about it or not. But we can note in the report that this is being worked on too, and maybe point to the Universal Health Commission website if a legislator wants more information.
Thank you. And so we'll quickly move to the next straw proposal, which is benefits and services. This benefit design is one of the key components of covered services and consumer cost sharing. So this is a priority in terms of getting some further information regarding that. Just a little bit of background from May 2024 to June 2025. The Commission and FTAC compare cost of benefit design scenarios. The Commission chose 3 existing health benefit plans to compare in the study. Medicaid with 100% actuarial value, the UMP Classic, which is 87 to 90% actuarial value, and Cascade Select Silver, which is 68%. Then an actuarial analysis completed in March 2025 compared the costs of pooling an identified population of Washington residents into each of these benefit scenarios. The results, the Commission determined that the UMP Classic, with the addition of dental, should be the starting point for the benefits and services design, and that a Medicaid-like design with no patient cost sharing should be an aspirational goal. The Commission also recommended retaining Scenario 3, the Cascade Select Silver Plan, standard benefits and cost sharing as a cost-neutral point of reference. And then based on this initial direction, FTAC formed the work group that we've been referring to refine the recommendation. The work group recommendations were provided to FTAC at the July meeting, and their feedback was incorporated into the straw proposal that's before you today. And just real quickly to go over those recommendations, the benefits and services design should be a standardized benefit design for all Washington residents in the new system. Again, these are the recommendations related to benefit and service design. And I'll just read that again just for clarity. The benefits and service design should be a standardized benefit design for all Washington residents in the new system. Second recommendation, retain UMP Classic as the starting point for benefits and services design under a universal system and include the same covered services as those covered by UMP Classic. The next recommendation was cost sharing design options should begin with establishing an array of cost sharing actuarial values from UMP's 90% AB to 100% AB. The next recommendation, when further defining consumer cost sharing, began by setting boundaries for key indicators known to drive consumer preferences. Such indicators could include premiums, services covered prior to deductible being met, amount of any deductible, use of fixed copayments rather than coinsurance, and out-of-pocket maximums. The next recommendation, ensure that any cost-sharing design aligns with the cost-sharing principles developed by FTAC and approved by the Commission. And finally, determine priorities for possible future actuarial and forecasting studies for the Commission's consideration. And so I'd open that up to see if folks have any questions. Again, the straw proposal is included in your packet. And I also would like to invite any work group members, if there's any additional comments or feedback you have on this that you'd like to provide to the group. I know Joan and Jane were here if they'd like to provide anything additional. Joan, please go ahead.
Yeah, thanks so much. My question on this one was about the I think you read it, the when further defining consumer cost sharing begin by setting boundaries for key indicators known to drive consumer preferences. Interested in learning more, or work group members have any further insights there. And I know costs are a big driver for customers, and then obviously there's also quality and network and some other things. So anyway, that was the piece that I would benefit from more clarity around.
Thank you, Joan. Would any of our work group members like to respond? Thank you, Eddie.
Sure, I'll chime in. So the cost control strategy, so I think we went around many of them, but we wouldn't like to have a small, I think it was just trying to come up with a structure on how to propose them with purpose. And that was the biggest thing. So in cost control, cost containment, so I get, sorry, what was your question again?
I guess my question is, I know in the exchange, for example, we design standard plans and we take into account sort of a standard plan design that tries to sort of allow for competition still on network and quality and premium, but then sort of has a more fixed cost sharing amounts and more services before the deductibles. So I was, anyway, I'm happy to learn more as the document continues to iterate. I'm not sure what it looks like to take into account, I guess it's like in setting the cost sharing amounts, folks want to be mindful of the principles that we know impact
Yes,
access
and that's
as
what
it
it came
relates to
down to
affordability. Okay.
as principles, because the effect of cost sharing can have an unintended consequence. And so I think there was a very mindful discussion around that.
Got it. Thanks. That's super helpful context.
Yes, and I'm just echoing those principles that were put forward by FTAC and concerns about changing costs in different impacts on different types of patients that would be purchasing a universal plan, and kind of the variability between co-payments and deductibles and how those can, change depending on circumstances or providers, is my recollection for some of those conversations.
And
Does
I think the inclusion of I like that the FTAC added the inclusion of a more sort of cost neutral point of reference, because I look at the UMP AV and I like it as aspirational and I see dollar signs. So I appreciate that. I appreciate the foresight there by the FTAC.
Thank you, Joan. Are there any other questions on the benefits and services straw proposal? Okay, I'll kick it over to Vicki again.
Okay, gonna get this right this time. Is there any discussion of the straw proposal? I didn't hear any proposed changes. Is there a motion to adopt the straw proposal and incorporate it into the 2025 legislative report?
I'm seeing an anguished face from Joan. I
was just trying to decide. It's hard. I don't know.
I mean, this is something different than how we've done it in the past, but really trying to get something down on paper. We've heard from the advocates. They really want to see and understand what we're working on better. This is a way to really convey that to everybody, including the legislature.
Yeah, I'm happy to defer to the group and our legislative friends here.
Senator Cleveland.
Thank you, Madam Chair. Just a quick point of clarification. If this were included in the report, if that were the outcome of the vote today to include it in the report, would it be reflected in the report that this is a straw proposal?
Absolutely.
Okay, thank you.
Yes. And we want people to understand that anything that we decide on, we're not setting in stone, we're setting in motion to move the work forward, to figure out in more details and give the FTAC an opportunity to really have a good understanding of the framework that we're asking them to do their work in.
And Vicki, I think my thought was around recommendations. Is this initial recommendations? Is this,
Yes, this is initial recommendations that are like you said, has been said, iterative. It's going to change over time, maybe not too much, maybe a lot. There's a lot of changes going on in the world right now that we'll have to really consider as we move this work along.
And I think that initially we had thought of these straw proposals as a way of, again, just putting this on paper, as frequently we were utilizing slides and just wanting to have kind of a consolidated status of what the thinking was, acknowledging that this is sort of a draft or straw proposal and that it could evolve, but wanting to ensure that we're being transparent and bringing along the public in the legislature and others as we continue to consider and refine, these different perspectives on eligibility and benefits and services.
So I'll just ask one more time if there's a motion to adopt the straw proposal and incorporate it into the 2025 legislative report.
I'll make motion.
Thank you, Teresa. Is there a second?
I second. This is Mohammed.
Thank you, Mohammed. All those in favor say aye. Aye.
Aye.
Aye.
Any opposed say nay. Okay, motion carries. Thank you, everybody. That was rough, but thank you. I mean, it's always good when we can have the conversation and make sure that what we're moving forward has consensus. So we're ready to move on to our final agenda item, and I'm going to lead a discussion about transitional solutions. And again, sometimes these conversations are uncomfortable. I think we're trained to hang on to our current institutions, and sometimes we don't know why, but just trying to be outside of the box and thinking of what we can work on. So during June and July Commission and FTAC meetings, we heard several ideas for transitional solutions, including mitigation strategies regarding federal changes like coverage losses, looking at the financial underpinnings of our current system to address affordability, stabilization of our current system, as example, maintaining people's access to coverage, supporting rural hospitals, building on work the Commission has done previously, and as example, administrative simplification and prior auth, something we heard a lot about in our public comments today. Developing a list of the transitional solutions the Commission has already identified to see what has already been done. Addressing healthcare workforce needs in rural areas, expanding and consolidating state purchasing. I think that's come up several times today. And then supporting small business, providing health insurance to their employers. And as an example for that, the Small Business Health Options Program that was originally part of the exchange. Members will also note that the Healthcare for All Washington shared some transitional solutions suggestions in their written and oral public comments today, including protection of current level funding of Medicaid, administrative simplification, consolidation, expanding state purchasing, streamlining purchasing of health benefit exchange plans, and addressing the impacts of the corporate practice on medicine. Given all these ideas, I'm hoping we can have a conversation today where we can prioritize and plan some next steps. Also want to note that in previous meetings, we have discussed how important it is we align with the Healthcare Cost Transparency Board and ensure we are not duplicating work. And there's plenty of work to do. We need to make sure that we're not doing something twice. Grateful to have Board and Commission Director Ross Valori, who just stepped out of the room for a second, here to help us navigate as well. So to kick us off, which transitional solutions do Commissioner members believe are most critical for advancing the state's readiness for universal health care system? And do you want to go backwards to the list?
Thank you, Audrey.
Oops. Oh. That one. Looking here. Are there any recommendations for transitional solutions commission members would like to add to the legislative report to put in front of the legislature ahead of the 2026 leg session? And then we do want to welcome our legislative members from to share insights they have on what would be most beneficial also. Representative Schmick, and then Joan.
Thank you. Can we define what financial underpinnings, just so I understand more what that statement means?
Oh, okay. That was from Pam McEwen from the FTech. I don't know, Eddie, if you have any thoughts on more definition to what the word underpinning meant.
Sorry. I think we just wanted to explore what that statement's saying is the to address affordability. So those are the things that are underneath or that relate to that. So I think there was just some questions brought up. So maybe that was too vague.
So, and this was in the July 17th meeting, so it was right after the HR1 passed, so maybe related to that.
That's true. We did have a discussion on that as well, because that does change the landscapes considerably.
Follow up, please.
Yep, go ahead.
Maybe just an example then, so I can better understand. Thank you.
So an example would be, $0 copays. I think it was things like that, just items that you could put in place. Or $0 premium payments.
Eddie, would the example of prevention, sort of not having a copay, be an example, sort of underpinnings of how we're saving consumers money?
Yes.
Thank you. Rep Schmick, any further questions?
Not at this time. I just looking for some clarity in the statements.
Thank you.
I will
Joan?
go review my notes and see if I lost something there.
Okay, thanks, Eddie. Go ahead, Joan.
Thanks, Vicky. Yeah, I think in how we're thinking about the exchange, we're focusing a lot on protecting coverage gains. So just trying not to slide too far backwards from where we are with the projected changes and federal rollbacks. So I think that's encapsulated by mitigation strategies regarding federal changes like coverage losses, and that feels right in front of us and important as we continue to want to move the uninsured number in the downward direction. So that's one that we're doing a lot of work on at the exchange that would be nice to bring to the commission.
Thank you. Senator Cleveland? You're muted.
Apologize. I thought I clicked it correctly. I have a couple of thoughts to offer. I think that the first priority should be looking at mitigation strategies regarding federal changes. But I think that goes hand in hand with the stabilization of our current system. I feel like those two I would see as priorities. I do have a thought to offer. Don't know if there's an ability to make any additions or changes, but that second transitional solution, looking at the financial underpinnings of our current system to address affordability. We have, a lot of efforts in the state looking at affordability. They're taking place concurrently. I would offer that we look at the financial underpinnings of our current system to address sustainability, viability, resilience, and then if we want to also include affordability that would make sense to me. But I feel like that second transitional solution is a little too narrow.
Thank you. Any other thoughts on any of these transitional solutions? Or other ones? Nicole.
I think hand in hand with the two that Senator Cleveland mentioned would probably also include the addressing the healthcare workforce need in rural areas, since there's potential problems on that front coming from the federal government.
Thank you. Any other thoughts? I myself am
If you leave
very
it in front of us long enough, Vicky, we'll probably just all pick all of them. So probably better to call us at 3.
We got 12 minutes. I'm very interested in the small businesses. I run one, and our premiums are through the roof. And I would just really think if we want to start moving towards universal coverage, if we could find a place, could SHOP be some kind of Cascade Care lookalike or UMP lookalike? And when can we start moving towards more of a self-funded plan and a TPA, so more like uniform medical plan? And I think that will get us moving towards the universal financing I think that we're looking for. And I had one more crazy thought on my list. And I think this came from the advocates. It's and I think somebody brought up today a Medicare supplemental plan, but what about a state option Medicare Advantage plan? Because that leverages some Medicare premiums into the state, so that brings more money into the system. I know there's probably some rules that you have to work around, but I think it's been done somewhere in a city, maybe San Diego, San Francisco. But we need to find a way to bring more funds into our system too, or we're just kind of stuck. So those are my thoughts. Anything else from anybody? I wasn't aware of the 1331 waiver. I think I was peripherally, but that Oregon is using that as bridge coverage. The tribes really used basic health plan. It was the basis of our health program at Jamestown for the 7 years before we got a clinic. And it was a great program. Okay. So here's what we have, Ross. Mitigation strategies regarding federal changes like coverage losses, and really putting that together with the stabilization of our current system. Addressing healthcare workforce in rural areas. And then looking at the financial underpinnings of our current system, but not just to address affordability. What were the sustainability? Yeah, to address sustainability and resilience. And then I threw out the things I keep telling you guys about, which are the state option for a Medicare Advantage plan and that small business option plan, but really more like a self-funded plan that looks like uniform medical. And we did hear from the advocates that labor is interested. So something like that, if we could do a plan that is really affordable and a good buy for them. We could get them to participate willingly without, none of these are like requiring people to participate. But if we can do these plans and they're good, we can get them to move there. That creates a way bigger risk pool and keeps the costs down for everybody.
Thank you, Vicki. And apologies, had to take a quick break. The context for the transitional solutions, we had talked about inclusion of these in the legislative report, or potential inclusion of these in the legislative report based upon the recommendations we get here today. Is that okay? Just wanted to provide that background in the context of kind of why we're talking about these, and for any additional considerations that folks have, that these could have the potential of being included in the legislative report and going in front of the legislature for their review. Also would be curious, noting we have a few legislative members with us today, if there would be any insights on what might be most beneficial from a legislative perspective to hear about regarding transitional solutions, if there's any insights there from any of our legislative members.
We did hear from Senator Cleveland and Representative Schmick a little bit, but I don't know if they have more to say. Yeah. Representative Schmick.
Thanks. I think everything is going to be budget driven this next session. So anything that costs money is probably going to fall like a lead balloon. There's just not going to be money available. Just reality of what, at least of what I anticipate.
Thank you. That a very practical and helpful guidance. Thank you, Representative Schmick.
So these items will be included in the report as things that we discussed. All right. And we'll drive the work plan moving forward into the next year. Any reservations about that? Are we good to move that forward? Okay, well, we're so worried about time, but we're going to be able to end a few minutes early. Any last comments? All right, the recording and summary of this meeting will be posted shortly on the Healthcare Authority's webpage for the commission. The next meeting is next month, remember, because we moved the August meeting out. So Thursday, October 9th from 2 to 5. Look forward to seeing you there. This meeting is adjourned and it is 4:53. Thank you.
Vicki. I'll take the 7 minutes. Bye all.
Thank you, everyone.
Thank you.
Bye-bye.
Bye.